Hello, my name is Monique Tiffany, and I'm an advanced practice nurse in cancer and genetics. I'm also a 19-year triple negative breast cancer survivor and a BRCA1 mutation carrier. So, this subject is very near and dear to my heart, and I'm very passionate about it. Over the next half an hour, we'll be talking about the connection between genes and cancer. And I hope this is something that you'll learn a lot from and be able to share with your family members. The objectives of this particular program is to just do kind of an overview of hereditary cancer. I want to talk about how we can identify hereditary cancer in patients when we're thinking about red flags or those common types of cancers that are associated with hereditary cancer syndromes. We'll also talk about the risk associated with hereditary cancer, and then also look into some of those implications that hereditary cancer can have on treatment, screening, and prevention, as well as the family impact. When we think about genes and DNA in general, we know that genes are made up of our DNA, and these are the instructions that carry out the making of proteins. This is how our bodies function. And these proteins have specific jobs that help our bodies to work normally when they're being produced normally. When we have normal gene function, it produces normal healthy proteins. But when we have genes that are mutated or there are variations in our genes that are not causing it to produce normal proteins, we come out with some damaged protein that can eventually lead to cancer. These can be hereditary in the fact that they are autosomal dominant, handed down from either the mother or the father. Most hereditary cancer syndromes are autosomal dominant, meaning that there's a 50% chance that they can be passed down from mother to child or from father to child. However, there are some recessive conditions that can cause hereditary cancers. When we think about these autosomal dominant patterns, we know that if mother has a mutation in one of the genes that could be associated with cancer risk, then she has a 50% chance of passing that down to her children. And so this inheritance pattern can be the same as if the father had the mutation, and it can also be the same inheritance pattern from passing it down to a son or a daughter. So this is one of those misconceptions because often we hear that if mother has a breast cancer causing gene, that she couldn't pass it down to her son, which is not correct. So mother could pass that down to a son. The chances of that son getting breast cancer in his lifetime would be less than we would see with a female, so that daughter getting breast cancer in her lifetime, only because breast cancer seems to be more common in females than in males for various reasons. So I just wanted to point that out. When we think about cancers in particular, we know that we usually put them into three different types of buckets here. Sporadic cancer is the most common type of cancer that we see, and sporadic cancers are those cancers that we really just don't know what caused them. We know that cancer is often a disease of aging. We know that there are lifestyle factors such as smoking that can increase the risk of cancers. But sporadic cancers really can't be pinpointed to say this particular thing caused this particular cancer. There are some cancers that we consider familial types of cancers. This attributes about 15 to 25% of cancers. These particular cancers are not generally associated with a gene mutation, but we do see family patterns. So sometimes mother has breast cancer, grandmother had breast cancer, perhaps an aunt had breast cancer. Maybe these are all happening in their 60s. They start to look kind of like a pattern in families. But like I mentioned, there's not one specific gene that's responsible for causing the cancer risk in these families. The difference with this is hereditary cancer can be attributed to a gene mutation. Sometimes it's attributed to more than one gene mutation in a family. And we see this happen about 5 to 10% of all cancers fall into this hereditary bucket, meaning that there may be one or more gene mutations going on in this patient that's causing the cancer that we're now seeing. Cancers that are hereditary are germline mutations. So these germline mutations actually form because mom or dad handed down this particular gene mutation when the embryo was forming. And this is a cancer that would be in all cells of the body. Now, all cancer is genetic. However, not all cancer is hereditary. So let's talk about what that means. Some cancers, like in the description on the left side here, are only happening in the tumor itself. So for this particular patient, there's not a gene mutation that happened in every cell of her body. However, we might see this somatic mutation that's happening just in the cancer itself. And this is important information to understand, but for different reasons. When we do somatic testing or tumor testing, we can look at these genes and these mutations that are within the tumor sample itself. This can really help to decide on treatment options for patients. Certain chemotherapies are better metabolized with certain types of gene mutations, and then certain types of chemotherapies might be a better choice for a particular patient than they would for someone who didn't harbor that particular somatic mutation. Germline testing is also a blood test. It's not a tumor test. So this is a test that we look at the blood because we can see all the cells in the blood that could be affected with a germline mutation. This helps us to also figure out if this is an inherited cancer, but it can guide treatment and it can help us to decide whether or not different management options are important for these patients. When we think about this in the big scheme of it all, how does this look when we're comparing these patients who have gene mutations compared to those who do not carry mutations? Well, we know that those who carry mutations often have multiple cancers or perhaps cancer at an earlier age. And as you can tell from this cartoon, that makes good sense. Because for someone who has a gene mutation, they've already got one gene that's not functioning properly. So it doesn't take as much damage to the DNA for a tumor to develop. As we look at someone who has no gene mutations and they have a normal function in their genes, you can see that it could be much longer for a tumor to develop because they would have to knock out both of those normal functioning chromosomes. So this really does explain that two-hit hypothesis that you might have heard about before. That really explains why cancers can happen at earlier ages with these hereditary types of cancers, and why sometimes we see multiple types of cancers in one patient. So let's move into some of the risks and some of the red flags that would really help us to identify these patients who might be at risk for hereditary cancer. We know that cancer at an early age is one of the biggest red flags. Cancers that happen under the age of 50 are really suspicious for hereditary cancers. So this is something that we want to consider when we see a patient who's young with cancer. Also, certain rare cancers. Male breast cancer is a very rare cancer. Sarcomas can be a rare cancer. They are often attributed to some hereditary cancer syndrome. Other rare cancers would include pancreatic cancer or ovarian cancer. So these are particular cancers where if a patient has one of these, they automatically meet criteria for testing for hereditary cancer syndromes because those cancers are rare and often associated with a hereditary cancer syndrome. And then also multiple cancers, as I mentioned. And these could be multiple cancers in an individual, or maybe they're multiple cancers that are happening in a family. So perhaps there's a lot of breast cancer, like I mentioned earlier, or perhaps there's ovarian and breast mixed into a family, or pancreatic cancer. Perhaps all of someone's siblings have had some type of a cancer. These multiple cancers are definitely a big red flag that something hereditary might be going on in this family. We know that multiple genes can be associated with a single cancer, And as you can see in the depiction on the left here, breast cancer has several genes that could be associated, causing that risk of breast cancer. And then on the right, you'll see that multiple cancers can also be associated with a single gene. So in this particular picture, this TP53 gene, which is associated with Li-Fraumeni syndrome, it can be associated with so many different types of cancers: breast, ovarian, gastric cancers, colorectal, pancreatic, melanoma, prostate, uterine. This is the concept that really tells us we need to cast a wide net when we're doing genetic testing so that we make sure that nothing gets left out. For someone who has a breast cancer and meets criteria, it would be especially important to make sure that we're covering all the bases with all of the different genes that could be associated with that particular cancer, which is why you see providers nowadays using multi-gene panels to try to incorporate all of those genes that might be causing cancer in this patient or in a family. When we think about the different genes that are associated with breast cancer specifically, we know that there are some genes that have a very high risk. Genes like BRCA1 and 2 and PTEN fall into a very high risk category. And then other genes like PALB2, ATM, CHEK2, those have a little bit lower risk, still a high risk, but we would consider those more moderate penetrance genes. When we think about the genes that are associated with ovarian cancer, again, BRCA1 is very, very high for that risk of ovarian cancer. But as you can see here, there are other genes that are associated with ovarian cancer, BRCA2, STK11, which are also associated with breast cancer, but also genes like MLH1, MSH2, EpCAM. Those are genes that are associated with a colorectal cancer syndrome. When we think about the other risks that are associated with these particular genes, and we pull out just BRCA1 and 2 in particular, you can see that that risk of cancer in females up to age 50 can be very, very high. And those secondary cancer risks can be very high as well. A secondary breast cancer risk within 5 years of that first diagnosis could be up to 20%. And that risk for ovarian cancer after a breast cancer can also be quite high. It's important that we're identifying these patients when they have that first cancer to hopefully mitigate those secondary cancers. I know personally that having a cancer diagnosis, one of the worst things I think I could possibly ever hear is you have cancer again. So if there's something that we can do to find out if this is a hereditary type of cancer before cancer develops, that's the most ideal situation. But at least at the time of that first cancer, hopefully we can identify patients who have that cancer risk in other cancer sites. When we think about those cancer risks that are associated with genes that cause colorectal cancer, we can see that there's also a large variation between different genes and different cancer risks. For those that have polyposis syndromes, which is many polyps in the colon that can increase that cancer risk, those that are associated with biallelic, meaning that they have two genes that are defunct in the MUT-YH gene, that cancer risk can be very, very high, up to 100%. Also, those in the APC gene can have very, very high cancer risk associated with them. And then again, those Lynch syndrome genes, MLH1, MSH2, EpCAM, those are still high risk, but they are a little bit different than you can see the PMS2 down here at the very end of the table here, showing that it only has up to a 20% risk. So these different risks are very important to just note when we're thinking about the risk of colorectal cancer and the risk of endometrial cancer as well. If you look at this chart here, it really shows you how the variations in these different genes can cause different cancer risk. And I'll just hone in right here on this second line here with the endometrial cancer risk, where you can see that if someone has an MSH6 mutation, this here in the dark blue, they have quite a high cancer risk for endometrial cancer. Where if they have a PMS2 mutation, that cancer risk is a little bit lower for endometrial cancer. Although both of these genes, in fact, all of these genes that are listed here, are all part of the cancer syndrome, Lynch syndrome. So how do we find out if someone has a hereditary cancer predisposition? Well, this is where we need to do germline genetic testing. And as you recall, germline genetic testing is the type of testing that we do with a blood sample. And we're looking at all of the cells in the body to see if they carry a particular mutation that puts this person at risk for cancer. When this testing is done, we can come back with a couple of different results. So positive, we'll start there, is telling us that there was something found in the blood. It could be one mutation in a gene. It could be more than one mutation in a gene. Sometimes people have more than one genetic mutation that could lead to an increased risk for cancer. For those people who have a positive gene mutation, then we know that their risk for cancer is increased. And oftentimes when we find this result in a patient who's already had cancer, we've been able to explain why that cancer happened. On the opposite side here, we have the negative results. So one thing that's interesting to say is that if you've had a family member who has tested positive for a gene mutation already, and they've had cancer, or perhaps other members of the family have tested positive and had cancer, and you test negative for that particular gene mutation, that actually tells you that you don't have the same risk as these other family members who have had cancer in your family. So this is only a very informative result if you have that situation, if other family members have been tested and there is a known family mutation. If you yourself have cancer and your provider gives you a multi-gene cancer risk test or a genetic test, and you come back with a negative result, it's not as informative because we haven't identified the reasons for cancer in you or in your family members if they also test negative. So this is a less informative negative than for those people who have already found a mutation in the family. And something that might get kind of confused is that in-between result, and this is called a variant of uncertain significance. And this particular result comes back occasionally because we don't know everything there is to know about genetics right now, and especially in cancer genetics. Although we figured that we found most of the major players that can cause cancer, we still are missing a lot of information. And so at this time, if you get a result that says it's a VUS or a variant of uncertain significance, this just means that we don't have quite enough information to make the determination if it should be classified as positive or as negative at this time. And so when we think about the medical management that we get from these results, we know that anytime a positive result happens, then there would be some medical management change based on that particular positive result, because that positive result tells us that there was something deleterious, something causing cancer. And so we can use that result to help manage patients more appropriately. This is different if you have a negative result or a variant of uncertain significance, because these results would be based solely, the management would be based solely on that family or personal cancer history. And so providers would not be using these two results to make any type of recommendations for future care. They would be relying on the information that they have gathered from your personal history or your family history to help them make those recommendations. Sometimes I hear people say, you know, it's all doom and gloom to do this genetic testing, but I want to let you know that even for those patients who test positive, this is good information to have. And in many times, many cases, it actually saves lives. And let me tell you how that happens. For those who have a hereditary cancer risk, and they get this positive test back, they can now make some choices in their life to help them to avoid risk factors, to help them do increased surveillance and screening for types of cancers. And in some cases, they might even be using risk-reducing agents, something like oral contraceptive to help reduce risk of ovarian cancer, or risk-reducing surgeries, where people are having a bilateral mastectomy to avoid breast cancer high risk, or perhaps a hysterectomy to avoid that uterine cancer risk. So this is really important information for patients who are at high risk to have in their pocket so that they can make better medical management decisions for themselves and help their family members as well. Because anyone who carries a hereditary cancer syndrome, their families are also at risk for carrying that mutation. So this is important information for families to know, hopefully, to be able to make some of these decisions for surveillance and risk-reducing types of strategies so that they can make better decisions for their medical management as well. And this is that opportunity to stop that legacy of cancer that's happening in families. When we have better information, we can make better decisions. So let's go back to that VUS, and I want to just talk a little bit closer about what that looks like, because I do feel like there's a lot of misconception around this. So a variant of uncertain significance sort of falls in the middle of this big ladder that we use to classify our gene mutations. And we know that with certain information, we can completely decide if something is deleterious or cancer causing. That's what deleterious means. Or we can tell if it's completely benign, and that's that polymorphism that you see at the bottom of the ladder. But sometimes that information is just not so clear, and so because we're kind of waiting on more data to surface, we might be needing more testing, we might need to see more patients with this particular variant before we can make this decision. That's where we would put, in this case, this particular variant as an uncertain significance. And what that kind of looks like, if we think about that, if we're writing a sentence and we're using the word gray, we would expect the word gray to be written G-R-A-Y. That makes perfect sense to most of us, probably to all of us. Sometimes we might see somebody write it G-R-E-Y. That's kind of more of a European way of writing it, but for most of us, that wouldn't change the outcome of the sentence that we were reading. We would still understand that there is the color gray going on here. However, if that word was spelled G-R-I-Y, that would be a little confusing. Are they missing a letter? Was there a letter put in there by accident? What are they really trying to say? So in that case, we can kind of compare that to what we would consider harmful when we're looking at DNA, because this is a misspelling that really is causing confusion. Some questions that come up around discrimination for those patients who have had genetic testing, I think is important to cover. And so I wanted to just take just a minute or two here to talk a little bit about that. Just to let you know, there are laws that are state for your protection against discrimination. And these really do help discriminate against health insurance or employer discrimination. There are some situations where there are exceptions. However, for patients who have been diagnosed with a cancer, this would never, ever be a reason to not get genetic testing, because cancer actually kind of outweighs any kind of protection that you would have from discrimination from health insurance anyhow. And so knowing this information, knowing if your cancer is hereditary, is really one of the most important pieces of information that you can have to protect you from getting cancer again. So I want to kind of just put your mind at ease there, that there are laws that are in place to help protect you against discrimination. Now, I will mention that this doesn't help with discrimination for life insurance or long-term care or disability insurance. And for those patients who are already diagnosed with a cancer, they are not going to have that protection either. But you are protected. There are non-discrimination acts that help protect against this particular type of discrimination. And so I want to help put your mind at ease that this information from genetic tests is very vital in helping you to be healthy and to make good medical management decisions. And so hopefully that fear of discrimination is not keeping anyone from doing this test. When all this is said and done, what does this really mean for you? What does it mean for you as a patient? What does this mean for your family members? Let's talk a little bit about that, because cancer incidence is very, very high. And if you just look at these 6 different cancer sites, we can see that the annual incidence of cancer is in the hundreds of thousands. Breast cancer and prostate cancer are very common cancers. We see those happening at much higher rates. Ovarian cancer and pancreatic cancer are a little bit more rare, but still 22,000 and 56,000 is not something that's small. And then when we consider the fact that many of these cancers, a high percentage of these cancers are actually related to our hereditary cancer syndrome, that's another thing to consider. If you remember back on one of the first slides, I talked about hereditary cancer being about 5 to 10% of all cancers. Well, I want to point out here in the second column that percentage of hereditary cancer can be quite different depending on the cancer site that you're looking at. In fact, up to 14% for breast cancer is considered to be hereditary cancer, which is why about a year ago, the American Society of Breast Surgeons actually upped their criteria for testing all breast cancer patients. And if you notice here for ovarian cancer, which has been in the guidelines for testing since about 2008, we know now that almost a quarter of ovarian cancer patients have a hereditary associated cancer. So the more that we're learning, the more that we're testing, the more that we're finding that some of these cancers have a higher percentage of hereditary cancer. So it's very important that we're identifying these patients that are at risk, because we've already talked about what some of those secondary cancer risks look like, and also those risks to family members who don't find out that they are carrying a genetic mutation as well. Knowing what your cancer risk can really help your doctor to make some life-saving medical decisions for you. So some of the things to keep in mind are any kind of personal history of breast cancer at any age, ovarian cancer at any age, pancreatic cancer at any age, metastatic prostate cancer at any age. These are all single indicators for testing for genetics. Colorectal and uterine cancers under the age of 65 is also a criteria for testing. If you're considering just family history, we know, like I mentioned earlier, breast cancer or any cancers under the age of 50 is a red flag. If you've got 2 or more breast cancers in one relative at any age, that's a red flag, multiple cancers in a patient or a family member. 3 or more cancers on one side of the family, you're starting to see some familial patterns, that's a red flag. And those cancers like ovarian, metastatic prostate, pancreatic cancer, male breast cancer, all very rare, and also cancers that are highly associated with hereditary cancer. Whenever someone is found to have a gene mutation in a family member, that would be a reason to get genetic testing to make sure that you also don't carry that mutation. And then certain ethnicities like Ashkenazi Jewish actually have a higher risk of breast cancer and a higher risk of hereditary cancers than some other ethnicities. So anyone with Ashkenazi Jewish ancestry should be very aware of breast cancer or any other types of cancers in their family history. Again, like I mentioned, multiple cancers can be associated with a single gene. And if we know that those genes, if we've been able to identify those genes that are found with mutations in this particular patient, we can really start to determine what those risks look like for people with those gene mutations. So breast cancer can be very, very high, up to 87% with some of those gene mutations. Gastric cancers can be very, very high. Colorectal cancer is very high. So understanding what those lifetime risks are for those particular gene mutations is going to be really helpful in making decisions moving forward for care. Secondary cancer risk, again, very high in a patient who has a BRCA mutation and they've been identified with breast cancer. They have up to a 64% chance of having another breast cancer by the time they turn 70. That's extremely concerning. For patients who have had colorectal cancer or uterine cancer, who carry a Lynch syndrome gene mutation, their cancer's risk for the next 10 years and 15 years can be extremely high as well for one of those other cancers that are related to Lynch syndrome. When we think about medical management, for those patients who have been identified with a hereditary types of cancer and have already been diagnosed, this can have surgical implications, a lumpectomy versus a mastectomy. Sometimes an extended colectomy for those patients who have Lynch syndrome would be more appropriate. Radiation may or may not be an appropriate treatment for a patient who has a hereditary cancer. That would be something to be considered, especially if that patient is thinking about reconstruction. So that's something that would have to be really considered by a provider to make sure that they're making the most proper recommendations for their patients. Treatments are also really, can be really associated with different types of therapies that would be more appropriate. Platinum therapies for those breast cancer patients, for those ovarian cancer patients, and even for those who have prostate cancer and our males with prostate cancer, platinum therapies might be a better therapy, and it might not be the first therapy of choice if they didn't know that they had a hereditary cancer. There's also more of a new kind of evolving use of PARP inhibitors, which are being used in those patients who have BRCA1 and 2 mutations and some with ATM mutations in metastatic breast, ovarian cancer, metastatic prostate cancer, as well as pancreatic cancer. So new therapies that are specific to having a genetic mutation are now available that are really helping to help with progression-free survival so that these tumors aren't progressing as fast, as well as just overall survival and quality of life. So these are different from chemotherapies that might be being offered. So something to think about when we're thinking about treatment in these patients. There are also risk reduction therapies. Aspirin might be used to help to lower the risk of colorectal cancer in someone who has a Lynch syndrome gene mutation. And something as simple as oral contraceptives for a patient who has a high ovarian cancer risk. If oral contraceptives are taken for 5 years, this helps to significantly reduce the risk of ovarian cancer in both carriers of BRCA1 and 2 mutations, as well as Lynch syndrome carriers. These also might help with future screening. So we find through genetic testing that people have other risks. And so perhaps a breast MRI is going to be appropriate, or perhaps a colonoscopy is going to be appropriate for these patients that we might not know that they had other cancer risk. And we might not know that they needed other types of screening modalities had we not done that genetic testing. So for family members, this can have a great effect as well. Like I said, this can be the thing that helps stop the legacy of cancer in your family. If family members test positive, they can talk to their healthcare professionals and make sure that they get good recommendations for screening, for prevention, for risk-reducing therapies, and possibly surgeries. And those who test negative, this is nice information for them to know as well. If you consider the family who's had lots and lots of cancer, and everyone's at some level of worry about the fact that they're going to get cancer associated with what's been going on with the family for years, and they get a negative result in a family who has already tested positive, that gives them that peace of mind that they're not potentially going to be at that same risk. And so that can be really helpful in just giving you some peace of mind about risk as well. For those patients who have not had cancer, those increased surveillance, methods of chemoprevention, which might mean taking tamoxifen, which is a hormone reducer in the body. So it actually reduces the uptake of estrogen for women who have a high breast cancer risk. So this is something that can actually be an option. And then risk-reducing surgeries, whether it's removing the breast tissue or removal of the ovaries and the uterus for those patients who have that type of risk, or perhaps in some cases even removal of the colon. But these are all risk-reducing techniques that would be available for patients, and having some options to be able to reduce this risk can really help a patient make medical management decisions, and it can help providers to do the most useful thing for their patients, the most appropriate thing for patients, once they know that they have those risks. And if you learned nothing from this whole presentation, I just want to point out a few of these very important things as you walk away today. Know your family history and the risk factors and red flags that might be associated there. Know those cancer histories. Know the ages of those family members who have had cancer and the types of cancer they've had and how many different cancers they've had. Do some research for yourself as well. Look into guidelines that doctors and your medical professionals are using. The National Comprehensive Cancer Network has a whole list of resources for patients. The American Cancer Society also, lots of resources for patients. So do some research for yourself and really be empowered. Talk to your provider about hereditary cancer risk and the testing that it involves. Sometimes providers are not inclined to bring it up, but if you bring it up, it causes them to be accountable, to have that conversation, to look into your family history, to decide whether or not you meet criteria. And even if they are not the one that does the genetic testing, hopefully by mentioning it and showing that you have some red flags, they can get you to the right professional that can help you get that testing done. And just understand that knowledge gives us the power to make informed decisions. And you are always your best advocate. So be educated, be your advocate, and be empowered. And thank you for your time today.